Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the NARM Training Institute. I'm your host, Emily Ruth, and I'm so glad you've joined us today. Hi, Transforming Trauma listeners. We're thrilled to share with you that the new NARM book is coming out on July 26th. The Practical Guide for Healing Developmental Trauma Using the NeuroAffective Relational Model to Address Adverse Childhood Experiences and Resolve Complex Trauma is written by our very own NARM creator, Dr. Laurence Heller, and NARM senior trainer, Brad Kammer. This book is designed to promote personal and collective change. The intention is to make NARM accessible for anyone working with or dealing with complex trauma. Using therapeutic examples and helpful exercises, Brad and Larry demonstrate how NARM can serve as a catalyst to promote healing and post-traumatic growth. Whether you are a mental health or other helping professional, or simply interested in personal growth, we hope you will find this book useful in your professional work and personal healing. The Practical Guide for Healing Developmental Trauma is available for pre-order now on Amazon and other online book retailers. Please visit narmtraining.com/books to stay up to date on the latest news, promotions, and giveaways. And now for our interview. Today, we will hear a conversation between Dr. Stephen Porges, originator of the Polyvagal Theory, and Dr. Laurence Heller, creator of the NeuroAffective Relational Model, as they discuss how our physiological state impacts how we perceive and interact in the world on a profound level. Dr. Stephen Porges, PhD, is a distinguished university scientist at Indiana University and the founding director of the Traumatic Stress Research Consortium in the Kinsey Institute. He is professor of psychiatry at the University of North Carolina and served as president of the Society for Psychophysiological Research and the Federation of Associations in Behavioral and Brain Sciences. The polyvagal theory emphasizes the importance of physiological state in the expression of behavioral, mental, and health problems related to traumatic experiences. He is the author of several books you'll find in the show notes and is the creator of the music-based intervention, the Safe and Sound Protocol, which is currently used to reduce hearing sensitivities, improve spontaneous social engagement, language processing, and state regulation. Please enjoy this conversation with Dr. Stephen Porges and Dr. Laurence Heller. I'm so happy to be sitting here with Dr. Stephen Porges and Dr. Larry Heller. Thank you both for taking the time to be with us here on Transforming Trauma.
Thank you.
Yeah, thanks, Emily.
Yeah. And as we do on this podcast, if it works for both of you, I'd like to begin by posing the question like we often do in a NARM session, and that is asking you both to consider what is it that you would like listeners to get out of our conversation today? And Larry, I'll let you take the lead from here.
Well, as I mentioned to Steve before we started recording, I've been a fan of his. His work has helped me to understand on a physiological level some of the things that I was already doing. So I'd like to talk more about that. I'm curious about current projects and research that you might be doing. And other than that, I haven't thought forward what I might want to get out of it, the session, or want the people who are listening to get from this. But I'm assuming that it'll be a friendly and interesting conversation, and look forward.
Well, thank you. I tend to agree that the fluidity of the interaction is where the gifts come from, that we'll learn from each other. My basic take home is for people to understand that their physiological state, what their body is doing, impacts on they perceive and interact in the world. It interacts on a very profound level because we literally are broadcasting our physiological state to those with whom we interact. So if our body's in a state of threat and we're highly mobilized, people around us are getting those signals, and they may not be so welcoming to us, even though our intentionality is to be welcomed and to attract and to support. So part of our dialogue will be this disconnect between our perceived or subjective intentions and what we are really doing.
When you mentioned something before we started recording, Steve, that was very reminiscent of the first title of my last book, which came out as Healing Developmental Trauma, but the first title was Connection, Our Deepest Desire and Greatest Fear. And that has to do with what we talk about as the core dilemma.
Well, let's start with actually deconstructing it from, let's say, a polyvagal perspective.
Okay.
And the answer is connection is our biological imperative. It's embedded in our genetic makeup. We want to engage. So in a sense, in the purity of being a human, it's not a conflict. It's not a dilemma. The dilemma occurs that through accessibility, we become vulnerable and we become injured. And then we retune our nervous system to be defensive of others who try to engage us. And that retuning of the nervous system doesn't always alert the intentional mind. So we still may think we want to be held, But then when someone comes and holds us, our bodies react and we pull away, sending a cue that we don't want to be held.
That's very consistent. Again, the not wanting to connect is a learned response, is the way I talk about it. And of course, there's a great deal of the body as well as the psychology that's involved in that. And so I think pretty much we're on the same page there.
Yeah. I would like to kind of emphasize it's learned, but when we use the word learning, we live in a cognitive centric, cortical centric world. So when people say you learned it, well, say, I don't want to learn it. I want to unlearn it. But it may be very difficult because it's learning within the body. It's like classical conditioning. It's like a conditioned reflex. Our body reacts through prior history, and the body has learned. And it doesn't always map into our intentions.
Well, part of in the NARM model is that history, we carry history with us in the form of the adaptations that we've made to difficult circumstances. So again, I think we have a slightly different language, but I think we're
Yeah.
pointing in the same direction.
Well, I think language, basically language is both helpful to us, but it also puts us into categories. So I always like to swing down to really where you're going. There's an intuition there, and that we may have different languages to describe that intuition, but we are basically intuiting and experiencing the world in a very similar way. And that's a good sign
Mm.
for our interaction.
Part of one of the things that I wanted to pass this by you is something I read that you had written, but I don't even remember which book or when it was, and I may even misremember it, so you can correct me. But one of the things that I talk about in my trainings, and I did this before I read your book, but it has to do with the importance for therapists of being open and being present. And the more, and tends to be a very strong tendency among therapists, the more they start to effort, the less present they become. And then I read your take on that using the polyvagal theory, and it seemed to support that point of view.
Yeah, well, it's in total accord with what you're saying. And I often talk about caregiving as a bad word or health care because it basically makes it appear in our language that we are giving something to the other. Our nervous systems really like the interaction. So if you think about a mother comforting her baby and then the baby cuddling and conforming to her body, then you start seeing the bidirectionality of that interaction. And I think all levels of human interaction have a bidirectionality. They're a co-regulatory strategy. And I think this notion of fixing things by giving people either words or tools doesn't quite work. We treat everything as if we basically have grown up in a world that thinks in terms of giving medicine, doing surgery to fix things that aren't good, and has a learning model that you basically shove information down the brain and then the brain will deal with it. It's a little bit more nuance that our nervous system on both a learning level and on a health level needs to feel safe in the context in which it is in. That it has to, in a sense, give up a very primitive foundational defense to have that accessibility. And in clinical terms, I think the words would be more flexibility in the setting.
Again, in the language that I use, I talk about relationality. It includes flexibility, and I've never deconstructed the word caregiving in the way that you just
Yeah.
did, but I do talk about compulsive caregiving or compulsive helping or those kinds of things.
It's really, I call it moral veneer. So I get even deeper into kind of like the underlying reason people do it. They think they're being good. And the issue is you think you're being good without understanding the impact of what you're doing. So yes, you're a good person, but understand you're broadcasting cues that are not helpful. And it's very difficult for people to reframe their effort as something that could be injurious to someone else, even though that effort is motivated by doing good.
Yeah, well, again, I think that people think that they're doing good, but often they're involved in a certain kind of enactment or reenactment of some of their own dynamics when they're acting compulsively.
Well, you see, we can just start off by saying, and this is what I often say, we're a traumatized species. That's our history. We're transgenerationally traumatized. And our journey to a type of normalcy is, can we get back into our body and can we feel the states that we're in? So can we be informed that when our physiology is in a state of threat, that we're not present with other people, we're broadcasting cues of separation and not connection.
And I certainly see and understand that perspective. I do bring in some of the attachment relational dynamics and what we learn through in adapting to connection failures very early on in life. That's what I mean in terms of what we have a tendency to carry forward, not just on a cognitive level, but on an emotional level and on a physiological level too.
Yeah, so the issue is not, from my perspective, is not to separate those domains. They're all part of the same. So the physiological level is the platform for what we call emotionality or affect. And that affects, literally modulates or mediates what cognitions we can have. So if your body can have at that moment, if your body is in a state of threat and mobilized, your range of emotion, your range of communication of emotion to others is limited and biased towards the negative. So it's like this is an integrated package. And how can we literally stop it at a moment so we can appraise it? And I think that's part of the goals of therapy. It's not to evaluate it, it's to truly experience it. And when I'm listening to you, when you're saying about history and learning, I'm in total accord, agreeing with you. I'm just concerned that when we use certain words, we start to place responsibility that if I've learned something, I now have the responsibility of unlearning it. If I see that the learning has retuned my nervous system, and that retuned nervous system then reaches and develops a personal narrative that supports being in states of threat, I'm locked out to the world.
Right.
So I have to stop justifying and using the narrative. I have to still get back into my body and understand those feelings, respect them. And I guess in the contemporary therapeutic world, we talk about self-compassion, self-care, but really it's self-awareness of where we are.
Yeah, I certainly agree with that too, because there's a duality that's created when we talk about self-compassion and self-care. Who's taking care of whom in that
Yeah,
duality?
yeah. But the duality becomes even an interesting term to use because we talk about co-regulation, and this becomes literally the structure underneath of which attachment is really based. It's that bidirectionality between individuals in which one individual supports the physiological homeostatic characteristics of the other, meaning making you feel safe so your body doesn't have to be locked in that metabolically costly state of defense. But there's also, you can even push the model and say there's a co regulation between our conscious brain and our body.
Mhm.
And that co regulation, you need to become aware of it and respectful of it. And that is when we say self regulation, which was the term I functionally grew up with. And this is the term that most of us, that you need to regulate yourself. And what that ends up doing is making people numb to their body. It's the body screaming at them with feedback. And you're saying, I'm not going to listen to that feedback because I can self regulate, I can control my behavior. And this creates, is as part of the pathologies, or let's say the uniquenesses of modern day society, in which we have people in bodies that they don't feel. And by not feeling their own body, they're projecting not cues of safety and inclusion and accessibility to others. They're broadcasting evaluation and dismissiveness and marginalization.
So now that I've got you here, I have a question that I've always wanted to ask you. You brought up transgenerational trauma, and that was kind of on my list of things that I wanted to get your point of view on, as well as just generally, how do you see trauma being communicated transgenerationally? So that would be my first question.
Well, all we need to do is, as I say, stand still for a moment. Don't look at ourselves in the mirror, just look at the world. And we're seeing, if you see the world without evaluation and you start understanding, you start asking really big questions. Why are people treating others the way they're treating them? Why is this going on? Because our biological imperative is that we need to connect. So why, in a sense, kill those that you need to connect with? Why marginalize? Why humiliate? Why send threat cues to others that you need to communicate with? And now you go back and ask the question, tell me about the history of humanity.
Okay.
And the history of humanity was always about defense. It was always about threat. And then it really wasn't always about safety. See, this is where I think polyvagal theory comes in. It makes this big separation between the removal of cues of threat and the production of cues of safety. Our evolutionary history, our phylogenetic journey, is all about cues of safety to turn off threat reactions, to actually have an antidote to threat reactions. Our cognitive brain has said, okay, threat's bad, so we don't need threat. Let's get rid of threat. It didn't acknowledge that that was just the beginning point. We need cues of safety. So let's even talk about the pandemic. Let's say the vaccine reduces threat, but does it create safety? No. Does removal of nuclear arms remove threat? Yes. Does it create safety? No. So we haven't gotten to that next step, and that is this true respect that our nervous system actually requires cues of safety. We know this when we have a baby. We know this when we have a puppy. We know that cues of safety are critical. But when we kind of get a little bit older, we become intellectual and we become building a different model. And we have lost contact with what it is to be a human. Cues of safety is that portal to enable others to become accessible and for us to be accessible to others.
And so, in terms of your work, then, working with people who have experienced trauma, how do you, in your approach, begin to address that?
Well, I fortunately can literally tap out of that question because I'm not a therapist. You see, this is now where I can wax and wane about the philosophy and the science. If I were to, is it's morph into a therapist perspective, I would start by saying it's tough. And when people have experienced severe adversity, their nervous system is now retuned to detect threat or to be biased to threat and not tuned to even be accepting of cues of safety. So we know it's very difficult. And we know that there are certain portals that the nervous system does react to that are cues of safety. But now, going back to your earlier point, that those cues of safety now for a person who's severely traumatized or severe adversity history, those cues of safety are now become cues of threat because they're cues of vulnerability and not cues of accessibility. And that is the interesting part of what I've learned from the world of trauma. I learned that you can't just turn off these threat reactions, even if you have the toolkit on board, because the higher brain structures have learned that if they do that, that part of the brain, that you are now vulnerable. And now you have a functionally an apt reaction. You'll react to that. So the example is intonation of voice, like which calms a baby and gets your puppy to come close to you. You do this to a person with a severe traumatic history, a trauma history. They initially may become, oh, and then their body goes into that state of accessibility. But to a person who has a trauma history, feelings of accessibility are feelings of vulnerability. And now you get this massive reaction of trying to get out of that place.
Yeah, and along with what you're saying, I can't tell you how many times in the course of a session, I'm not in private practice any longer, but I was for 40 years, but I still do demos in groups. And it comes up again and again is that at a certain point when I'm working with somebody, they'll look up at me and they'll say, I see you're not judging me. And they'll take a deep breath and they'll settle more into their, or it's already started, but it's part of that growing awareness that they're shifting the cue, the imagined judgment that they had before,
Yeah.
in terms of just exactly what you were talking about, and it changes.
So many people, okay, so there are all these different flavors of therapy, but they have some common features, and that is this notion of presence and support. I like to use this term being a good witness. And I think that it's not merely that of a therapist, but it's a human being. I don't think we have a sense of, I'm going to almost use another bad terminology. We haven't really learned to be good witnesses. We haven't been, that hasn't been fostered. So when we're a good witness, we have this sense of broadcasting our compassion to the other person's feelings, and we're not evaluating it. It's not the same as empathy, which is another sloppy word that gets floated through the therapeutic world, because from a science perspective, empathy is literally feeling the other person's feelings. So let's put us in the state where you're a therapist and you're empathic with a person telling their trauma history, and you start to cringe and you start to react. And what you're broadcasting to that survivor is that what they're telling you is hurting you. And this, of course, they don't want to do that. So they don't want to talk about it because it creates pain. But if you have this degree of compassion, this degree of support, of witnessing the other, then the person feels like they can express themselves. They're given their voice back. And that's what you're saying about that moment in therapy where the client says, I have my voice. I can be accessible without being vulnerable.
Mhm. And I can be vulnerable without worrying about you judging me because there's a sense of safety
Do
here.
you see the words really can create problems? So I'm going to now take your words, reinterpret them, now create another problem. But we're saying that I can be emotionally vulnerable, I can be intellectually vulnerable, but I'm not going to be viscerally vulnerable. So I can, in a sense, move through those experiences without my body interpreting it as a life threat. And that occurs, I believe, when we have experience moving in and out of those states. So where those state is no longer that red flag.
So when you say moving in and out of those states, what do you mean exactly?
Moving into that state of vulnerability
Oh, okay.
and realizing that that's part of I'm now vulnerable, but you're going to react to me in a very supportive way of being present, and I'll be co-regulated by your presence, and that vulnerability will then be neutralized by the literally cues of safety that you're broadcasting, not just projecting, but literally broadcasting to me with facial expressivity, intonation of voice, gesture, and posture, not necessarily with narrative.
No, I would agree. And in the work that I develop and teach, there's so much less orientation to narrative than in most of the therapies that I have trained in and know. And there is a different way, but a very significant way of referencing the body as part of the regular process. And I encourage people not to take trauma histories. That's not the way to meet people, you know?
Yeah, I resonate to what you're saying because the history becomes a narrative, and the narrative becomes a justification for being in a state of vulnerability or state of injury. And the real issue is not the history leading you to that. The real issue is, can you describe that feelings in your body at this moment?
Yeah, I get that. And the things that I bring, to people's attention at least is this whole focus on cognitions and behaviors that leaves out emotions in the body is, from my point of view, so limited. And
Mhm.
so I've got a little bit of an axe to grind in that area because,
I'll help you sharpen it. Okay.
okay, you do that.
Well, the part is, it's kind of like when you're a parent. You think all behaviors are intentional that your children have. But when you were the child, you're being run by your visceral state. And, you feel tired, you feel cranky, you feel this way. The point we're making is that even when adults lose their physiological state, they become, as non-contingent in their behavior, they become oppositional. We tend not to respect the power that our bodily state basically imposes. I'm going to use the word imposes because it creates a platform upon which our behaviors can emerge. It's not necessarily causal, but it contributes. And if we're aware of it, we learn to navigate those bodily states so that when we, quote, start to lose our physiological regulation, we become more mobilized, more reactive. We're aware of it. And we say, well, if I'm in this state, what is that telling me? It tells me I'm going to overreact to people around me. I'm going to have a bias in how I see things. Maybe it's good for me to just leave and go for a walk. Let me start to monitor my own body and learn skills of calming my body.
So I have a question that might take us to a different place in a certain way. Curious, are you familiar with Rachel Yehuda's work? One of the things that comes out of her work, obviously, then is that how her initial studies on women who were pregnant and directly exposed to 9/11, and then, they were diagnosed with PTSD both by biological markers and by psychological, tests, and then having the infants of those mothers being born with the same biological markers as the mother. So, given her research and what she's done with Holocaust survivors after, since then, I'm just curious what your point of view is on that kind of trauma, the prenatal, for example.
Well, you used a loaded word.
Okay.
You used the word biomarker, but it's a loaded term because people tend to think of it as a static or trait variable and not a state variable,
Mhm.
if we go back to earlier psychological conceptualizations. And in fact, so much of psychiatry was about looking for biological markers because then it could be pathologized and treated with
Mhm.
pharmaceuticals. Polyvagal theory takes a very optimistic viewpoint. It says that often our nervous system gets retuned into a state of threat. It's not rewired, it's retuned. And this means that we can move into states of safety if the cues in the environment can support that. So what you're talking about is transgenerational retuning of a autonomic physiological state that is really in support of threat and defense.
We then run into the question, so what do we do with clients who've experienced that?
Well, you see, there are two things that would lead to totally different journeys. One, if you went to the notion of, quote, a biological marker, and people say, oh, well, it's epigenetic, I've retuned this system, and this is my destiny. Basically, it's a personal narrative of this is what you have to live with. Or you can say that this is a miraculous retuning of my system through the flexibility of the nervous system under states of duress, and given an environment that is supportive and patient and witnesses, the system may become less prevalent, and the system of spontaneous social engagement, the system of co-regulation, the system of trust and safety may start to emerge. It's a much more positive one.
Well, I also hold a certain kind of optimism about these things because again, I think your point about biomarkers or biological markers is well taken, and it's just a snapshot in time as opposed to, and it's subject to change. We certainly share that. I'm, as a therapist, having been a therapist for most of my adult life, my focus is obviously clinical. And what I've seen is that with people with these earliest kinds of adverse experiences, changes is frightening. And as you pointed out, it takes some time.
Excuse me for stopping you there, because you really made this important statement, and that is change is frightening because change violates expectancies, and our nervous system sees violation of expectancies as threat. And this is at a higher level. So predictability, regardless of how horrible it is predictability. And the nervous system kind of gravitates to that. But displacing that predictability with unpredictability is catastrophic for a nervous system in a state of threat. So that we have to understand and respect. And we can see the narrative being played out where people, they are in a physiological state that creates this defensiveness. And that creates a narrative to support being in that physiological state to create defensiveness. It becomes a self-fulfilling closed loop. And the real issue is, can you now just take a time out, stop, and be aware of the state you're in without the narrative, just with the physiological feelings? And can we explore the physiological feelings? And then can we move physiological feelings and what emerges with that? Some breathing, some posture shifts. I think the people in dance movement therapies actually had a real, in a sense, an insight that when you carry with you a trauma history, it's certainly a lot easier to find a portal of engagement if you're moving. Because if you're immobilized, that is the threat. Immobilization is total vulnerability. But if you're moving a little, you have your sympathetics on board, and maybe you can allow the social engagement to come on while moving.
I know that that will certainly and does work for some people. I guess my concern is for like these kinds of clients that most therapists struggle with, who any shift really in their internal state, even specifically towards any kind of what we might call positive shift, is experienced as threatening.
Yeah.
And so then there's this immediate bounce back.
We've seen that I developed this acoustic intervention called the Safe and Sound Protocol, which when I developed it, I thought was a stealth intervention of, I called it in my own language, distilled essence of trust in acoustic signals. Think of the mother's voice. So it's an amplified prosodic changes by computer amplifying prosodic changes from vocal music. So people listen to it, they don't know what they're getting, but they're getting these physiological shifts. And I was stunned by the fact that people with severe trauma histories would get up and have to leave the room.
Yeah.
And I started to realize what was happening because I could actually start seeing videos. People would listen for the first minute or so, their bodies would become basically ventral side opening up, becoming is what we call safe and accessible. And then the interoception, the feeling of the body, got up to their higher brain structures.
Hmm.
And those higher brain structures associated that accessibility with severe vulnerability. And they were going to get the hell out of that space. You have that in the world of mindfulness as well. When people start to meditate, close their eyes in a group, suddenly they're vulnerable. They can't stay in that room. They have to move. So it's understanding that, yeah, we can get the body into a state of accessibility, but is that where the higher brain structures want the body to be? And I think this is the discussion. And we're always going to move now. The higher level of the brain learn not to be in those states. Now, how does intervention work? How does therapy work? Well, it works through literally titration. It's in a sense a sampling of those physiological states, and now a relearning that those physiological states are not the trauma. They're physiological states. That's what they are. And they give you the range of experience in the world.
I understand what you're saying. I like the way you put that. And again, as we all do, I have kind of putting it together with what I believe I know and what I teach. And so, but ultimately, in the NARM work, I talk about the functional unity between the psychological and the physiological. That for every psychological state, there is a physiological, but it's not even a correlate. I was going to say correlate, but it's more than that. It's this functional unity piece.
Okay, I just finished a paper. It's open access, it's online, it's in Frontiers. It's called Polyvagal Theory, a Science of Safety. And in it, I talk about where I came from in terms of the psychophysiological background and literally a belief in, when I started, in psychophysiological parallelism. And that's what you're really describing. And I said that was a fallacy because it didn't understand the evolution of our nervous system, which started from simple to get to more complex. So it's basically hierarchical. And so the brainstem area, which is really about regulating physiological state, is the substrate for all these higher cognitive and brain functions. So you can have a one state of the autonomic nervous system of your brainstem functional foundational system be creating portals to many higher brain functions. And so it's not one to one, it can be one to many. And what we need to think about is what is the neural platform that we want to be standing on, or we want to be functioning on. And it's a neural platform of feeling safe because that opens up portals, not just for co-regulation, sociality, but also for learning, cognition, problem solving. It is what makes us this remarkable species if we can be in physiological states of safety.
So, a question to kind of continue with that I have for you. And I'm just curious in terms of some of the things that, again, that clinicians run into, like shame, self-hatred, self-rejection.
Mm.
How do you relate to those dynamics through the lens of your theory?
Well, slowly.
Okay.
It's because there's stretches, because a lot of what we do in our own professional life is really through not just the lens of our scientific and theoretical perspective, but through our own life experiences. And so the world of trauma taught me a lot because my history was not severe trauma. In retrospect, it was a good life and has been a good life.
Mhm.
I think the world of trauma teaches us what the heroic uh, journeys of people who experience severe trauma is remarkable because they teach us what it is to be a human. So these become the issues. The issue of shame, when we make that statement, the first thing that comes into my mind is where do you feel the shame? And if you say I feel it in my gut, I know what it is. It's subdiaphragmatic. It's going very much into a life threat reaction. So it gets linked to that. If you say I feel it in my heart, blame, you might feel it in your heart. You say, I'm now in a dangerous situation and I want to get out of there. But when you feel it down in your gut, you want to disappear. Because it's really recruiting a very ancient defense system, which was immobilization, slowing down, basically almost hibernation. You're going to appear not to be alive. It's death feigning. And shame may trigger that in some people. So we have all these psychological words we use. And from my perspective, I want you to tell me where do you feel it? Then we can put it into the perspective.
I tend to see it in people, in particular, as more of a whole body response, as a kind of collapse response.
But you see, it is a whole body, but collapse is this deafening subdiaphragmatic response. So it's really, yeah, what's driving the system? Is it get the hell out of there? Is it disappear? Or is it
Mhm.
how are you, Larry? It's like your nervous system basically has three major circuits it can use. Now it can make hybrids. So like freeze becomes this kind of hybrid. You're not going to totally disappear because you could die. It's not physiologically viable to lower heart rate so much that you pass out. But if you get a little sympathetic tone, you can maintain upright position and space out. And that's what freezes. It's a nuanced immobilization with less risk than the shutdown. And what is dissociation? Dissociation is another getting out of there, but it's another nuance. It's now utilizing even higher brain structures in navigating out of there. So, in a sense, dissociative or parts become ways that our body navigates through complex situations, reducing biological risk to having, in a sense, the more classic shutting down responses.
And I think the clinicians are wondering out there, so Okay, that's really interesting and it makes sense. And what do we do about that?
Okay, so the rubber hits the road with
Yeah.
these clinical questions. And what I've done is actually I've learned from clinicians. I've actually, when I talk at conferences, I just don't only talk. I often listen. And the issue is, what do you learn? You learn that people take this model and they say, well, they integrate in what they're doing in terms of their clinical package, what it is. And the issue is, polyvagal theory says respect physiological state. Let's just start with that. To respect it, be aware of it, understand that physiological state functions as a platform for different classes of emergent behaviors, and then understand that there are portals of regulating physiological state. There are cues of safety, but if you have a trauma history, cues of safety have to be titrated. So, like the Safe and Sound protocol, I developed a lot of, or let's say several. There are a couple hundred trauma therapists now using it. And what do? They start off by using it literally as an assessment. They let the person listen for a couple minutes and they ask, how do you feel? If they report no destabilization, they listen for more. And then if they get destabilization, they talk about what does that feel like? It's a journey of re-embodiment. And then they allow that nervous system of their clients to resolve. Sometimes it resolves almost immediately. Sometimes it takes days. So what they start learning, the body learns that it can engage that state over time and not be destabilized, as long as the therapist is attentive to the client and understands that the client is shifting states. And some of that shift is fine if they exhibit a degree of flexibility and resilience. If they become destabilized, that's part of a discussion and an understanding and a respect for it.
So when you're the therapists that who are using your work then have that kind of discussion, how does that discussion go?
Well, the discussion goes slowly. The point is because remember, for many people with complex trauma histories, feeling their body is something new to them or something that they haven't really wanted to visit. And so it becomes in itself destabilizing. And then it becomes a discussion of the feelings and what do the feelings mean. And that discussion through as a psychoeducational model allows the client to become more comfortable with the feelings without going into that personal narrative of what those feelings are associated with or why they should feel that way. So it's like re-exploring one's body, re-exploring feelings. And as long as we keep the narrative from reinforcing defensiveness, uh, the person progresses. But we've learned, or at least I've learned from the therapist, that for some clients, they can handle only a couple minutes a day or a couple minutes every other day. But what they reported back to me is that clients do benefit from it. And the issue now is the therapist interfacing with the client to go at the pace that the client's nervous system can handle. When I initially developed the intervention, there was a view that more was better. So you needed to just power through it. And the metaphor that I used once I developed this was less is more, because the whole approach of the Safe and Sound protocol was the reduction of acoustic features in the music. It wasn't putting features in, it was taking stuff away. So it was allowing the nervous system to process the unique cues of engagement or safety and trust. And the part that we're learning is that for some people, it's a lot for them to handle. And it doesn't make them defective. It just means that their journey is a little bit slower.
If I'm remembering correctly, but you use some of that acoustic work that you do with autistic children, is that correct?
It started with autistic children. And I would say that that was a very interesting journey. And it was also a misdirection when we moved it into the trauma world. The misdirection was I never saw adverse reaction. I never saw any of that reactivity to calming down. I saw these miraculous shifts in physiological state, auditory hypersensitivity, and spontaneous social engagement. It was very thrilling to see a person one day who would be looking at you this way, the next day reaching out and saying, "Hello, Dr. Porges." It was like, I mean, get up in the morning for that. You see, and you realize that it was merely the child's body was changing state, and in that changed state was spontaneously engaging. It was not a learned behavior to be social. It was the emergent property of physiology. That's what I learned. So I got real excited that the world of trauma was interested in applying this. And I had no inkling that the cues could be so profound to a person with a trauma history that they would react, basically become destabilized. And my initial reaction was, I don't want to be in that space. I don't want to be the conveyor of stimulation that makes people destabilize. And I really was basically saying, we need to be careful who we deliver this to. Well, the therapist had a different viewpoint. They said, this is powerful. Let's see if we could use it. And they were the insight. They provide the insight and direction. They said, let's see if we do it slowly, what happens to these nervous systems. Can they start to accommodate and use more and more? And what they start to find out is that they could use the SSP with their existing therapeutic strategy, but it accelerated progress. In a sense, it worked on that physiological state, and there are other interventions that could work more rapidly.
Well, and that particular one of my focus has been on very early traumatized individuals, and having seen just how challenged it is, and this internal flight is the way I talked. It was very parallel to what you said
Yeah.
earlier, and different ways of getting away, trying to avoid the sense of vulnerability or danger that they experience. And I've seen how incredibly titrated it needs to be for some individuals. So,
We sit back and say, oh, this is just, for me, it was like, how could this be? It's just some music I'm listening to, and I've taken out some frequencies and modulate how the others occur. This is functionally nothing. Okay. It's like the world we live in. How can this trigger in our body such a profound reaction? And then I started to think about, we did a study recently got published on maternal vocalizations and baby's heart rate and distress signals following the still face procedure. So in the still face procedure, the mother's playing with the baby for 2 minutes, and then she holds a flat face and doesn't move for 2 minutes, and then she re-engages the baby. But during the flat face, still face, the baby gets basically hyper reactive, starts to reach out. And we're talking about 9-month-old kids reaching out to try to literally calm or bring the mother back into the engagement. And so we measured autonomically and behaviorally the infant and measured the acoustic features of the mother's voice. If the mother's voice had more prosodic features, more intonation within a social communication frequency band, then the baby's heart rate was rapidly slowed up during the reunion. If her voice was less prosodic, no change in heart rate. Similar things in terms of distress behavior. So you could see with the infant the basic mechanisms of the safe and sound protocol. When the voice had more intonation, more prosody, which is what the safe and sound amplifies, those intonation changes, then the heart rate of the baby calmed down. It wasn't the words, of course, because it's not the words. Because, like you talk to your dog understands you if you have a dog or a horse based on intonation. And this is really our true phylogenetic history. And that is, mammals co regulated and cooperated, not through language, because early mammals didn't have language, but through intonation of vocalizations. And there's a very deep biology to this, because the nerves regulating the laryngeal and pharyngeal muscles are vagal. They're basically parallel vagal nerves, so that the nerve that controls our heart rate and enables us to be calm literally has branches that that parallel that nerve, those pathways, that basically puts intonation into our voice. So the intonation of our voice is really broadcasting our physiological state. And our bodies respond to other people's intonation, because the phylogenetic history is that intonation is telling you whether their physiology is safe to come close to.
one of the things that I invite therapists always to pay attention to, which is the increase in prosody in their client's voice, because that's telling you something very important about what's going on in the entirety of them. And
Oh, absolutely. They also have to be aware of their own voice, which sometimes, becomes an issue. And, when people become burnt out and exhausted, like many people have during the pandemic, it retunes their autonomic nervous system and their voices
Well,
change.
again, that's why the relational piece, I think, in both of our perspectives is so important, because if that's not present in the relational piece, then is failing. And uh, and that's the problem when therapists get mechanical, get efforting, and really miss the person who's sitting across from them because they've got some kind of protocol in mind.
Yeah, this is an interesting thing to deconstruct. So when therapists become more manualized, they may not be in the right physiological state to convey the cues of safety and connection to to their clients. So there's this, as I said, intertwining of learning your skill and also learning about your own body and the body of your clients. And often the trainings become disparate.
True, and at the at great cost when we become mechanical.
Well, again, if we put it into the context of healthcare treatments have tended to be external to the person. You give them medicine, you give them surgery, you do things to them. And this is where polyvagal theory really jumps in and says, forget that. That's part of the equation. But the state of the organism, the physiology of that organism determines whether that cause and effect relationship has any validity. The physiology has to support accessibility. So even like an ABA model, a behavior modification model, that in ABA, no one talks about physiological state, but physiological state determines whether those associations will be developed or not.
I completely agree, and that's what the R in my work stands for, the NeuroAffective Relational Model, and that relational piece, I'm certain, is an area where we agree.
I use the word sociality. Like Gabor Mate talks about humanity. And I say, well, what you call humanity, I call sociality. And what I call sociality, you're calling relationships. And I would say that relationships are all based on this ability to be safe with another, co-regulation, a mutual trust, cues of safety being bidirectionally conveyed. So I think we're saying the same thing.
And that issue of trust is essential. So, well, it's been great to talk with you here today, and thank you for your time and your expertise. I hope we get the opportunity to cross paths again.
I certainly hope so. Well, I hope we get to meet each other. That would be very nice, face to face. I think I am on once every 3 or 4 years. So, we're
Uh,
very, very good friends, but he likes to do some type of
well,
rotation.
I happen to be in the rotation this time, so I was just thanks. I was just hoping I
Congratulations.
might meet you in person. Yeah.
Hopefully next
All right.
time.
Well, take care, and we'll talk.
Listen, good to meet you, Larry and Emily. Thank you.
Thanks so much for joining us for today's episode. To find more about our guest and their work, check the show notes or visit us at narmtraining.com/transformingtrauma. The practical guide for healing developmental trauma is available for pre-order now on Amazon and other online book retailers. Please visit narmtraining.com/books to stay up to date on the latest news, promotions, and giveaways. Thanks to Andrea Klunder and the Creative Imposter Studios for producing and editing, to Tori Essex for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community, connection with you, and changing the world by transforming trauma.